This lecture is for EXS 221, Lifespan Nutrition, Chapter 12, Adult Nutrition. Similar to our other units, this is the start of Unit 3, and we're going to start with the changes in the lifespan that are normal and how nutrition and nutrition recommendations relate to that. So to start off with, thinking about growth and development in the way that we thought about it in other time points in our life, there are physiological changes that occur in the adult onset. Now, keep in mind, we are defining adult in this particular context as being anywhere from 18 to 60. So we have a really wide range of demographics that we're talking about here. So that kind of makes it difficult to narrow down to some of the major issues. However, this is a time point that we have talked a lot about in other classes and in the context of, specifically I know in the context of chronic disease, we typically are talking about adults. So it's important to understand how growth and development occurs in a normal adult to understand what goes wrong in the pathophysiology in chronic disease. So with those physiological changes, typically young women are fully developed by 19. Young men, typically it takes up to about 21 because they are still a lot of times gaining additional muscle mass, height, and weight. But what we know is the actual aging changes that we see physiologically start to decline at about age 30, which in preparation of these slides made me feel really terrible. So the rate, however, that we experience these physiological changes really is highly individualized. So depending upon lifestyle choices, physical activity, nutrition, any of those things, but also it could be based on environmental factors. So exposures in your environment related to maybe housing, air quality. And then lastly, it could also be genetically related. The clinical manifestations it's got over there to the right kind of let you know what we may actually be seeing in relation to that. So for example, as we start to see lean body mass and muscular mass decrease, with a decrease in that skeletal mass, a lot of times we see a weight change. Typically we see older adults start to lose weight and lose some of that strength and functional capacity. So as I'm sure most of you are aware, body composition, one of the ways that we utilize to understand how physically fit somebody is or their lean body mass to fat mass ratios, it changes as we age. And once again, during that third decade of life, so in the 30s, we start to see a natural decline in lean body mass and an increase in adipose tissue, which may be why a lot of people say, oh, well, I was really able to maintain weight until I hit my 30s and then I wasn't able to. So it's not always noticeable because somebody's weight may stay the same, but their actual body composition changes. But sometimes, particularly as we age, some of these changes might actually be noticeable in activities of daily living, which up until this point we have not defined, but it is really important as a health professional to understand this particular terminology. Activities of daily living are any of the things that we do on a day-to-day basis that are considered to be normal for us. So for example, grocery shopping, maybe sweeping the floor. There's a lot of different categories within it. We talked about it in community health if you have already taken that class, but there are some things that are also independent activities of daily living. There are some facets of that that are cognitive activities of daily living. So physiologically, we might actually see differences in what people can do from a functional capacity standpoint. So there are some changes to our endocrine system as we age as well. For women specifically, we see a decline in estrogen levels that lead to that normal change of menopause. However, when this happens, that actually increases the risk for cardiovascular disease, as well as decreases lean body mass. For men specifically, the decline in the testosterone levels leads to something that's less commonly discussed, andropause, where we see a natural increase in the fat mass, a loss of that lean body mass again. And specifically for men, we're also concerned about insulin resistance in conjunction with that increased risk of cardiovascular disease. Further, thinking about endocrine for both genders, the growth hormone actually starts to fall with age. This is called somatopause. And it happens in conjunction with a decline in an insulin-like growth factor, actually IGF-1. We see a reduction in protein synthesis, and as a result, we see a decrease in that muscle and bone mass and a decline in immune function. So overall, we're just seeing a gradual decline of the particular hormones that are helping our body maintain that lean body mass. So it's almost like physiologically, normally, things are kind of working against us anyways, which is why our lifestyle choices can really help bolster if that's kind of working against us anyways. So we've talked a little bit about lean body mass changes, but I want to define a few things because they're very important to understand for adult, older adult, and geriatric. That term is sarcopenia. So this is the normal age-related decline in lean body mass. Now, I do want to make the differentiation that it's different than cachexia, and we'll talk about cachexia a little bit with cancer patients, but cancer patients typically, or any patient that is having a significant decline in lean body mass that potentially leads to malnutrition, suffer from cachexia. And so once again, that's a relationship to an inflammatory process, an illness process where you have a lean body mass change. Sarcopenia, on the other hand, is specifically related to age. So we kind of expect this to see this with aging. It's just a metabolic consequence of it. Once again, it's thought to be in your 30s that this actually starts happening. However, diet and exercise are factors that can impact this lean body mass loss. Within that, physical inactivity can actually lead to a loss as much as 3 to 5% of your muscle mass per decade. So including strength training in physical activity and exercise regimens for adults and older adults is extremely important in maintaining that lean body mass that they already have. Further, because we know naturally food intake declines with aging, we'll talk about why that is in just a minute, making sure that the foods that are being consumed are as nutrient dense as possible, so getting more bang for your buck is extremely important. Make sure you know the 3 stages of sarcopenia and understanding that it does happen in phases where you have, in that severe sarcopenia, you definitely have the loss of the muscle mass with that functional capacity in that strength. So another thing that happens is our bone health actually changes. So around 34 years of age, our bone mass loss begins. And this specifically has to do with the loss and the decline in estrogen in women and testosterone in men. However, once again, going back to that, what's going to happen to everyone versus what we can control, about 20 to 40% of bone mass is actually influenced by diet and exercise. So it's going to happen anyways, but some of it is preventable or is slowing the process, slowing the decline. So that is really important to understand. And some of the micronutrients, I just wanted to point out that as our bone mass loss begins, some of the things that we have to be extremely careful about from a micronutrient standpoint is our bone health vitamins and minerals. If we are consuming a balanced and varied diet that is full of calcium and phosphorus and fluoride, all of those that are specifically related to bone, and then we know vitamin D also plays a role in that balance between calcium. Also, sodium and magnesium are extremely important for bone health. So as long as we are getting adequate amounts, but not too much specifically of sodium, we are also ensuring that some of those protective factors that might increase bone mass loss are being taken care of. So we want to encourage, particularly in the 20s and 30s, adequate intake of calcium, vitamin D, phosphorus, those types of things that would promote bone health. There are also natural metabolic changes that occur. So as I said before, as we age, the nutrient intake or the dietary intake that we take in decreases, meaning we typically consume less calories. So why is that? Well, if you remember our conversation in 219 or maybe in other classes about energy expenditure, one of the main ways that energy is expended is through resting metabolic rate, or some people call it basal metabolic rate, kind of same but different. So as we age, what our body needs calorically to function, remember BMR is just, if you were to do nothing, it is all body processes minus digestion and absorption. So what our body needs in order to complete all of those necessary functions actually declines with age. So meaning it kind of adapts to that concept that like, okay, well, I'm going to need less and less, I'm losing lean body mass, I'm losing bone mass loss, I need to protect less. So as that basal metabolic rate decreases as we age, sometimes what happens too is we end up taking in less food. Our body adapts to that and doesn't maybe signal hunger as frequently. So as adults age, sometimes what happens, particularly in older adult populations and geriatric populations, is that they eat less and less. So once again, meaning that when they eat, we have to ensure that the nutrient density is as high as it can be. Now, as far as like how quickly the BMR actually changes as we age, we don't really know a lot about that. But what we do know again is with all of these age-related changes, continuing to maintain physical activity at the national recommendations, along with strength training and eating a balanced and varied diet can be very protective in maintaining quality of life for as long as possible. Because instead of talking about growth and development in children and adolescents previously, now what we're really talking about is maintenance of quality of life. And that's a very important discussion we're going to have when it comes to adults, older adults, and geriatric, is that death is inevitable. But what we can do with our modifiable risk factors is ensure that what life we have left to lead is as quality as possible. So there are some major factors that affect dietary intake during the adult years. And one of them that we've talked about time and time again is overweight and obesity. Make sure you absolutely know those BMI classifications. We've talked about this over and over. I'm not going to hit it hard, but we absolutely know that this stems from that inappropriate energy balance. So that could be related to that reduced physical inactivity or the reduced physical activity. With a rise in technology, we see that increase in sedentary behavior. We know there's potential genetic links, but also the conversation we had related to adolescence about that obesogenic environment still is very much important. Why do we care about this? Well, we know obesity is directly linked to developing chronic conditions, including and not limited to heart disease, stroke, type 2 diabetes, certain types of cancer. And from a larger perspective, if for those of you who had community health, we're talking about an impact on the economy and healthcare systems due to the medical consequences related to it. So this idea that that obesity is an epidemic and has huge consequences is clearly true. And one way that we're trying to address that as health professionals that I want you to be aware of is part of Healthy People 2020. And so those 10-year science-based national objectives for improving health of Americans, one of those major topics because of this is nutrition and weight status. And so what Healthy People 2020 is wanting health professionals and policymakers to take into perspective is that not only do we need to change those individual diet approaches to change those behaviors, but also we have to have policies and environments that support these behaviors, meaning maybe a reduction in obesogenic environments, maybe a change in food industry, maybe a change in the way that we offer nutrition assistance programs. So for those of you who also had community health, for those of you who haven't, this will be coming up at some point in the near future, but that socio-ecological model thinking that those higher effects of the rainbow, the policy and the environmental effects, have such a greater impact on the individual than just simply going and telling somebody to eat more fruits and vegetables. So another thing that affects dietary intake of adults that I'm sure you're all aware of, and those of you who took 219 with me probably addressed one of them, is fad diets. So fad diets, a lot of times I categorize them as a weight loss diet that promotes quick results for little effort. However, it's really important to understand that these sometimes can be harmful to health, whether it's physiological health or mental health, because a lot of times with fad diets, we see that sets up a pattern of disordered eating, which can then lead to negative thought processes that could lead to eating disorders. So it's a huge cascade effect, right? And when we've talked about weight loss in the past, remember healthy weight loss is 1 to 2 pounds a week, and we have to be in a caloric deficit, whether that is simply from food, increased physical activity, or a combination of the two. Now, what makes a fad diet different is a lot of times it doesn't apply to those rules. A lot of times they're weight loss products where maybe they've bumped up the niacin in it, and niacin naturally makes you feel a little shaky, so you feel like it's working. Or maybe potentially it's an appetite suppressant, like green tea extract. I know has been one that some of the discussion about it has been that it reduces how much you want to eat. Not been proved to be actually effective from a clinical standpoint, but people do try it. The negative side effect of that is sometimes with that excessive supplementation, it can make people have GI upset or feel overly caffeinated sometimes. So one thing I want to encourage you as you go forward in the future is be able to pick out some of those things that might make something a fad diet and really try to promote the idea of what healthy weight loss looks like with those long-term behavior changes as opposed to these quick result programs. So some of the things that I want you guys to think about is when things seem too good to be true. So substantial weight loss really quickly. Quick weight loss, normally we're talking about a quick loss of water weight normally, and then quickly after that sometimes muscle and bone loss, especially if people aren't being physically active with strength training in conjunction with whatever they're doing with their food. Severe restriction of food items. So thinking about the potential deficiencies that could occur with that, but also thinking about once you set up your brain for that severe restriction standpoint, sometimes that really sets up that disordered eating pattern perspective. I love this one, blood type food matching. I mean, I don't even know what to say about that. I don't feel like I should have to say anything about that. There's no scientific basis for that. Such strict food plans that you're not able to indulge in your favorite foods, because what does that do? We know that that does that yo-yo diet concept where you restrict to the extent that you binge, and then you regain the weight anyways, and then we're talking about disordered eating patterns again. And remembering that any healthy diet should include physical activity as a key component, and typically they're not talked about together necessarily. So one term I want to make you aware of, specific to the eating disorder world, that I feel like is really prevalent in the adult population, but very not well understood at this point, is orthorexia. Orthorexia can just be considered an unhealthy fixation with how much you're eating, with the pureness of the food you're eating. This one really typically starts out as an innocent attempt to eat healthier and then slowly becomes this fixation on eating in a particular way. So it may have nutrition components with it, it may have physical activity components with it, and it may be really hard to pull apart that it's a disordered eating pattern. Technically, it's not clinically recognized as a diagnosis in DSM-5 yet, but what we are seeing is that self-esteem quickly becomes entwined with a person's diet, and they associate everything they do with what they're eating. And what we do know from that is that does require professional treatment in order to treat. So just be aware that food logging is great, self-monitoring is great. But as we said before, a little bit of moderation and a little bit of grace with oneself about what we eat and how often we work out, it's when it kind of interferes with that daily living perspective and people aren't able to separate, oh, it's my birthday, I can have a piece of birthday cake if I want and do it within moderation and an appropriate portion size without swinging the other way, okay? And being so obsessed with it that they feel like they can't have it. And so just thinking about if you are trying to assess adult patients and trying to determine if someone has orthorexia, once again, I would not recommend saying, oh, you have orthorexia or doing any type of diagnosis, but just being on the lookout and thinking about this as you're talking to people about diets, people that are talking about a clean or a perfect diet with that elimination of food groups, but then maybe they might have severe anxiety around meal times and what they can consume at social gatherings. They spend an excessive amount of time like menu planning, and that's a hard one to see because menu planning is great, right? Thinking about the foods that you're going to eat is great. When does it interfere with daily life? And that would be my statement to you. When am I not able to any longer go to work, go take care of my children, do whatever it is I'm supposed to do without feeling guilty for not doing these things? So thinking about nutritional recommendations during the adult years, we've seen this over and over. We do the estimated energy requirement, and remember for adults, we do that based on age, gender, height, weight, and the degree of physical activity. So we've talked about it before, but remember, most of you probably did the assignment in 219, even if you had Dr. Steves or Dr. Haydu. But you have to add in that physical activity level to really understand how much people are burning as adults, and also remembering, as we've already talked about, that the RMR decreases with age. So that's why that age component is really important. What a 25-year-old adult will need estimated energy requirement versus a 60-year-old adult is wildly different sometimes. I wanted to give you some key terms that you should already know, but are very important in this discussion of energy balance and the way that our bodies deal with expenditure. So I just wanted to remind you about what basal metabolic rate was, and that is the largest energy expenditure, and it is really what our body, it's all of the bodily functions that need to occur, excluding digestion and absorption. Now, thermic effective food typically raises your RMR about 10%. It's about 10% of expenditure, roughly, and it is simply digestion and absorption of food. So those are the two that are non-negotiable and non-changeable for the most part for adults when it comes to energy expenditure. Your physical activity level, or your PAL, is really the second largest factor impacting your expenditure, and it's the one we have the most control over. It can be as low as 20% or as high as 40 or 45%, depending upon how physically active you are. And if it's that high, where it ends up impacting is not TEF, but it actually makes your basal metabolism more efficient the more physically active you are. So just remembering your macronutrient, oh, that says micronutrient, that's so sad, acceptable macronutrient distribution ranges. You will see in the book a 20 to 35% of calories. I've checked my numbers again, and this is what the Academy of Nutrition and Dietetics is currently recommending, so I'm not sure what the discrepancy is there. I've seen it in different texts before, but I'm going to go with the 10 to 30% that you guys have learned and just keep my eye out to see if something shifts. So if you do see it in the outline, that's because it came from the textbook. I'll try to be consistent with what we have done in the class all along, but if I make a mistake and there's some sort of quiz where I'm going off what the textbook says and I get it incorrect, please let me know. Remembering that carbohydrates, what we're wanting is more whole grain options and getting adequate fiber, making sure you know that adequate fiber typically is about 25 to 38 grams daily. Protein, remembering that RDA for adults is 0.8 grams per kilogram in a healthy adult of body weight per day. And then in fat, the big thing to remember is that it is essential. We should choose healthier fats, but we want to limit the intake of sat fats to below 10% of daily total kcals and make sure we get our essential fatty acids, which are omega-3s and omega-6s. The underconsumed nutrients for American adults, typically we're concerned about potassium, choline, and magnesium. The reason we're concerned about those three in particular from a mineral standpoint is we know we get a lot of that from a well-balanced diet that includes fruits and vegetables and whole grains. And what we know about the American westernized diet is that for the most part, we don't consume enough of those foods. So we definitely are concerned that a lot of Americans are under consuming these minerals. As far as calcium and vitamin D, part of what we're concerned with there is that bone health perspective. And so where do we get those things from? Well, dairy foods, right? So dairy foods and potentially some fruits and vegetables. So knowing that, unfortunately, we don't get enough of that either. And specifically with the vitamin D, as sedentary behavior has increased and use of technology has increased concurrently with it, we know that adults are less likely to get the amount of sunshine that they need to convert the vitamin D. For iron, we're particularly concerned about adult women during the time prior to menopause when they're having a period and in their childbearing years. Sometimes we don't get enough iron. So that is a particular concern. So I'm just going to talk through some of those key ones that I talked through earlier. It covers a lot more in your book, but I really tried to keep it down to the ones that I thought were particularly important that we see most often in the population. So as far as vitamin D goes, we know that we should be getting a majority of it from the sun, but a lot of American adults are vitamin D deficient. And so this deficiency a lot of times is particularly common with someone who might be lactose intolerant or have a milk allergy. We see that a lot more now. So finding other vitamin D rich sources for that person that are not dairy items can be difficult. We also see it in our vegan population. Our best dietary sources, if they're not getting it with the sun, are the flesh of fatty fish and fish liver oils. So this might be the case where it might be helpful for this particular person to take a supplement. And in that case, I would definitely, for the specific IUs in the prescription there, I would definitely have them tested for vitamin D deficiency and have their prescribing doctor prescribe what they think is necessary. But recognizing that it is a potential problem in modern society. Potassium, as we said, the potassium deficiency is directly related to lack of consuming appropriate fruits and vegetables. And the reason this matters is, as we know, potassium is an electrolyte that is very important for muscle and nerve functioning. And that normal body functioning depends on that tight regulation of potassium levels. I will tell you from a blood level standpoint, when you draw it on somebody, it's a very tight range between 3.5 to 5.5. And if you go below or above that, you can see serious metabolic consequences, including arrhythmias and death. So thinking about ensuring that our society is getting adequate amounts of a healthy diet to get potassium is extremely important. Magnesium is another one because it is such a cofactor for over 300 plus cellular reactions and involved in many of our metabolic pathways. It's really important that people are consuming adequate green leafies and whole grains to get adequate magnesium. Those are the three big deficiencies I tried to focus on, but the one that we have to worry about that we get too much of is sodium. And so if you remember from 219, actually a lot of the sodium we take in, about 2/3 of it is actually related to commercially processed foods and eating out. Very little of it actually has to do with how we prepare foods at home or the salt shaker on the table. And it's important that we have sodium, right? We don't want a no sodium diet. We absolutely need sodium. So we do find it naturally occurring in foods, but it's that processed food aspect that really pushes us over the mark. We need less than 2,300 milligrams per day, and what we know is the average adult gets double that. So any ways that we can find to reduce salt for adults would be really, really critical. So how do we talk to people about maintaining a healthy lifestyle? Well, the first place I would clearly send you is the dietary guidelines, remember, because we are the ones who use those. We publish them every 5 years. It is intended to help you in the future give scientifically backed evidence. And for an average healthy adult, we know that what we need to be telling them is making appropriate food and beverage choices at appropriate portions, focusing on variety and different types of food items and making sure our foods are adequately nutrient dense, trying to limit our calories from sugars, fats, and sodium, and making sure that we are shifting to those healthier food choices. Additionally, we need to be talking to them about physical activity, and you should know this like the back of your hand at this point. We have to have that aerobic physical activity. We need at least 150 minutes a week of moderate intensity or 75 minutes a week of vigorous intensity. There's actually a lot of really new cool evidence out about HIIT, high intensity interval training. I wouldn't say I feel comfortable enough from a research standpoint to recommend this solely, but I've been reading some stuff about how even just a 12 to 15 minute appropriate HIIT session 3 times a week can hit what you need for your physical activity guidelines to improve health. Now, like I said, it's very new, but it's kind of exciting to see because we're constantly playing this idea of convenience and not having enough time to be physically active. And there's a potential with the HIIT style training that we're getting more bang for our buck. Also, we know there's a lot of benefits to physical activity. We know that we need strength training, so make sure you really understand those guidelines. Lastly, let's talk about some interventions for risk management. If you were in community health, I feel like I've said that a lot this particular lecture, I'm sorry, but these are some of the key things we talked about. You might want to take a look at your notes again for those of you that didn't have it. Here's an overview of some of the different terms that we use in the field about prevention and promotion. So health promotion is a pretty general term to help people have healthy lifestyle and healthy eating patterns earlier in life. So we're really talking about like even before they're thinking about it being a problem. So in true health promotion, we're talking about building healthy environments for children and adolescents so they're healthy adults, right? That's health promotion. Prevention, on the other hand, is really thinking about decreasing the risk related to some type of chronic disease. So in primary prevention, what we're trying to do is we're trying to postpone the onset of disease by creating healthier lifestyle patterns. So like, as we said earlier, we know that our bone mass, we start to lose it over as we age. That's normal. But if we can talk to adults in their 20s and 30s about consuming enough vitamin D and calcium, we can try to mitigate some of those risk factors to developing osteoporosis. Now, on the other hand, secondary prevention is when you are trying to help people who already potentially have the chronic disease and you're trying to help them manage symptoms and avoid further disability. So thinking about that quality of life perspective, so you have a 55-year-old female who already has osteoporosis, you can't go back in time and change that. And you really can't change it by giving her a ton of supplements of calcium and vitamin D. You can't reverse that, right? But what you can do is you can ensure that she does strength training, maintains physical activity, continues that nutrient-dense diet, prevents falls to prevent any further complications related to her osteoporosis. So make sure you understand the difference in those. And lastly, I just want to remind you about what SNAP is, because it is Federal Assistance Food Programs for adults that fall below that 130% of the federal poverty line. And so a lot of people always forget that that's previously what was called food stamps. I fully expect for you to know to call it SNAP, though, the Supplemental Nutrition Assistance Program. And that concludes the lecture for Chapter 12 for Adults for Lifespan Nutrition.